Greetings and welcome to AWHONN Insights, the home for candid nursing conversations. Today, we welcome guests that developed AWHONN's Respectful Maternity Care program, or are leading nationwide efforts to ensure that healthcare professionals are providing respectful maternity care for every patient, every interaction, every time. Dr. Shawana Burnett, Director of Nursing Excellence Programs at Advocate Health, an AWHONN board member, and RMC Framework Development Team member. Maggie Runyon, founder of the nonprofit Your Birth Partners, with a mission to cultivate inclusive, collaborative birth care environments rooted in autonomy, respect, and equity. Kimber Stovison, a recent CNM graduate, Oregon chapter leader, a past emerging leader, and current co-host of AWHONN Insights. And Sarah Koppel, Director of Perinatal Programs and the staff lead for the Respectful Maternity Care program at AWHONN. I'm your host, Bria Anopise, and I'm joined by Jessica Irobali, Director of Collaborative Programs at AWHONN. This podcast episode provides one nursing contact hour. To receive the contact hour for this continuing education activity, participants must 1. Listen to the entire podcast episode, 2. Complete the evaluation in full, and 3. Submit all required documentation by the stated deadline. None of the planning committee members, content experts, or presenters has any relevant financial relationships with ineligible companies to disclose. This activity received no commercial support. This enduring material will expire on January 20th, 2029. The Association of Women's Health, Obstetric, and Neonatal Nurses is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. AWHONN is also approved by the California Board of Registered Nursing Provider Number CEP 580.
It's a privilege to be a part of this conversation today. Over the past year, several videos have circulated widely on social media, including one that shows a patient in visible distress while the clinical response appears to be limited as the patient progresses into labor. Situations like this have prompted important discussions about care practices. In that context, I'd like to explore how respectful maternity care and trauma-informed care relate to what we may be observing. Specifically, I'm interested in what insights emerged from recent research and how respectful maternity care can serve as a potential framework or solution to address these types of care experiences. For listeners who may be new to this topic, how do you define trauma-informed care in the context of maternity and perinatal care?
Thanks, Kimber. I think that's a really important conversation and starting question for us with this because there are a lot of definitions floating around out there. I want to share one that I developed with Mandy Irby and Paula Rojas Landivar when we were working on the trauma-informed birth nurse program, which is that it is one element of organizational change that prioritizes the individual as the leader of his or her own health and recognizes how person-centered care shifts unhealthy power dynamics to mitigate the potential for trauma found in each care interaction. And I want to call out a particular aspect of this, which is that we recognize that trauma-informed care really should occur as part of organizational change, and that a trauma-responsive system has to recognize that both patients and staff can be harmed by inadvertently toxic and stressful environments that are frequent within healthcare.
I think that's a really important point to point out, that those that are caring for them and the patients are also can equally be affected by what's happening in the room. And I think it's really hard to understand that sometimes you're a part of the problem, but maybe even inadvertently so. I think it's really hard to accept that you can do harm if your intent is still good. So I think that's really important that you point out that, both parties can be harmed even if one has the power dynamic in a situation. Why is leadership perspective so critical when we talk about implementing trauma-informed care in clinical settings?
I think this is particularly critical because while I often speak about the power of champions in this work, I also know that it's not sustainable to count on individuals to bring forward and make these necessary improvements in perinatal care without leadership support. And part of that is that we need to let go of the quote unquote hero rhetoric in healthcare. It also can't be about the leaders shouldering this responsibility of transformation on themselves. We really need to understand the multiple perspectives and levels of care that are involved here if we're going to be able to work towards actually consistently implementing trauma-informed care.
That's such an important point that individual bedside providers can't be the ones that shoulder the whole weight of the system. It really just has to come from like so many different levels of the system to enact system-wide change. Your study found that overall attitudes towards trauma-informed care were favorable among leaders. What stood out most to you in those results?
So first, I was not surprised at all to see this. I talk to perinatal leaders on a regular basis who are deeply engaged in this work. Our professional organizations, right, have been calling for the routine use of trauma-informed care in our care, from AWHONN and ACOG, our colleagues, and our nurse practitioner colleagues, midwives. Like, we have been talking about this for several years now. And the importance of recognizing birth trauma and the possibilities for re-traumatization during perinatal care are referenced extensively in AWHONN's own Respectful Maternity Care framework. So this feels really like an affirmation of a tide turning in this. Just, we've really established this awareness of the importance of trauma-informed care, and seeing these positive attitudes show up, across the board in the leadership was a great sign of that.
As far as with your leadership, and I know that you're saying that there's tons of like layers, what does system-wide support look like for trauma-informed care to show the greatest variation across responses? So what does that variability tell us? What about the current hospital environments?
Yeah, so this also wasn't surprising, because in talking to clinicians and leaders across the country, I have heard of huge variations in our standard of care. We know that unit culture can vary tremendously across regions of our country or even within the same city. And paying attention to that culture and what's flowing through on a systems level is crucial and really deserves more of our attention. I think often we've been kind of limited to looking at those kind of interpersonal reactions, the one-off patient-facing routines. But as we mentioned at the beginning of this recording, we know that many people continue to experience substandard care and obstetric violence. And these acts of obstetric violence do not occur in a vacuum. And so it's necessary to really examine the culture that supports them. And part of that has to do with understanding what system supports exist or is absent for trauma-informed care as, one lens to consider. Because there's this gap between principle and practice. And it's one of the most pressing and difficult issues for us to address within perinatal nursing. Often I hear frustrations from clinicians and leaders alike who are trying to figure out how to do all of these things at once and how they can fit on adding one more thing to their plate. I think until we have this shift in the foundation, we're going to keep seeing trauma-informed care viewed as an extra rather than as truly a foundation of our practice. And that makes it feel kind of like business as usual. And that is despite those best of intentions that we have around this. And I saw that reflected from these leaders as they express their frustration and this kind of angst in this system subset of our data, to really see that they want this. They believe in the power of trauma-informed care, but their system is just not set up to support them or their clinicians in rolling it out.
So if I'm a leader and I want to revamp my foundation, I want to rebuild it, put new plaster on it, what are some practical steps that I could take to move from the positive attitudes about trauma-informed care to meaningful, sustained implementation where we don't revert back to the old culture?
Yeah. So the good news is that we know how to do this. We know how to translate these positive attitudes into new practices that feel manageable for nurses. And in fact, some of my research has even shown that they can improve how nurses feel about doing their job, and we can lower our rates of secondary traumatic stress. This is achievable, but the bad news is that it doesn't happen overnight. It requires an iterative approach with frequent reflection and adequate time to pause and connect with this material and then apply it in our practice. And so often we've seen kind of one and done solutions offered around trauma-informed care. And again, well-meaning and well-intentioned clinicians and leaders have rolled out, oh, everyone needs to do trauma-informed care training. We're going to do a 1-hour webinar and then check. We are trauma-informed. And we've seen great improvements, right? That tide has turned. We're seeing really positive attitudes for trauma-informed care. But it hasn't been the repetitive and ingrained continuous work that we need to make that change. And because that looks like collaboration with our colleagues across, all disciplines that are involved in perinatal care. It looks like using simulation tools and standardized patients to really understand how our care is received and perceived by our patients. It requires reflection. And ultimately, we also need policies to support and back up this work so that nurses don't feel like they are fighting the system to provide a trauma-informed approach when that is what's needed to respect their individual patient.
Thank you for that. I also, when I was reading your article, and we'll include it in our notes, you were also talking about we have to assess our culture or assess our organization to see if we're ready to take this approach and to apply it and sustain it. Can you tell me a little bit about the assessment tools available?
Yes. So there's two big ones. The ARTIC, which is the Attitudes Related to Trauma-Informed Care Scale. We use the 45-question version in our study, and it is a long, long survey. So I do recommend, there's great value in it. There's a lot of, big subscales you can get into, but there is also a 10-question version of that, which really looks at attitudes towards trauma-informed care. It's very, it's kind of basic. There's not any subscales in it. It's 10 questions. I think that's a great place to start to understand those attitudes, because if you have not yet seen maybe that tide turning, if you haven't had any exposure, on your unit to this education at a broad scale, that might give a sense of just where you're at and where to start. The other tool that I think is, particularly helpful is the TICS-10. And that really helps us to look at that unit culture and the systems that are in place to support it. So it's the trauma-informed climate scale. Also an adaptation that includes only 10 questions. And it's a really intentional recommendation to lead with that one, because so often we think to leap right in with our actions and our patient-facing policies, which I too love and appreciate. But a hospital is going to have a much more nuanced and a clearer look at where they're at when they can see their specific circumstances in there, because that includes questions like, if I'm upset at work, I know that other staff and supervisors will understand, or I feel like I have a great deal of control over my job satisfaction. The administration here does not share decision-making with the rest of the staff. It really starts to delve into how trauma-informed care is received on a system level by clinicians. And once we have that information, I think then we can look at tools like AWHONN's Respectful Maternity Care toolkit to see, okay, how do we bring this bridge, kind of this awareness between these theoretical issues, these principles of trauma-informed care, and recognize what needs to change within our interactions, whether those are our patient-facing ones and or the ones with each other, with our fellow clinicians. I see, respectful maternity care, which I also would have loved to see named trauma-informed maternity care, as really the antithesis to the care that allows obstetric violence to continue. In other recent work with Mandy, Paula, and our colleague Kristen Pascucci, we work to define the culture that allows obstetric violence to persist. And I just want to call that out because as leaders are considering, what it means or what is the point, right, of this new framework and creating a whole new foundation of trauma-informed care, I really want them to understand that we defined obstetric violence culture as referring to systemically embedded, institutionally sanctioned, and socially normalized conditions that perpetuate harm towards people with a capacity for pregnancy during childbirth. And I really believe we have the power to disrupt this culture and to elevate our care so that respectful, trauma-informed maternity care is truly the standard for all birthing people in our country.
That feels like a really thoughtful like integration of that toolkit into like our current system, because so often I feel like we're told to provide this care when the culture itself doesn't support it, so you're almost being asked to pour from an empty cup. So it feels really thoughtful and intentional to assess like where everyone's coming from and where your starting point is when you're talking about rolling that out to like the patients that will hopefully benefit as well as the staff.
I was just gonna kind of chime in on the aspect. I love everything you're doing with the trauma informed care. I will add in one caveat. I do think trauma informed care is one piece, and I think one of the reasons why I think I like the term respectful care, because it encompasses a whole lot of different facets that come into play there. And I often challenge people to think about, when we say trauma informed care, they often think about the negative experiences or the bad things that happen. I often share with people that sometimes trauma feels good, and trauma didn't feel like it hurt. So people aren't aware that they've even experienced trauma. And when we look at the way some of our healthcare teams show up, they don't even know that I've experienced trauma. That doesn't allow me to see you as a individual and respect that your way of living may be different than mine, and it may be best for you, even though it's not something I can empathize with or put myself in that position. And I think that's one element. That's one thing I like about all of the different ways we're approaching implementing respectful care in care environments, by allowing people to truly assess, not just their environment, but who they are and how they show up. And your past trauma as a healthcare worker, when you show up, sometimes, that is your mental block, because why is that a problem? It wasn't a problem for me. And they have a hard time just even being aware that this is an opportunity for me to show up and do better. And that's one thing I really respect about AWHONN's Respectful Maternity Care resources that they provided. It challenges people to think differently, because I do think we got to stop just looking at the problems that we see or feel, because some of the underlying issues that cause people to show up disrespectful don't always hurt or don't always, leave a scar. There, some of those are underlying, and I think it's important for us also to look at those positively reinforced behaviors that builds trust. That's the solution to the problem. I mean, we can keep pointing our fingers at the problem all day, but if we don't connect it back to how can we turn this in a positive way, and how can we figure out what are those positive things to reinforce that my trauma made me want to dig into respectful care and wanted to make me want to make sure everyone has a voice in their experiences. And, so it can be turned into a different perspective. So I think that there is definitely an opportunity for the two to integrate together, because I think it's important for people to know and respect their own trauma, because I think that is the foundational piece as to what is the barrier between education and action. I can tell you all day long, but if you don't feel it or see your barriers to being able to accept it, that's where we're not really getting to the outcomes and the data, because we can talk the talk, but we don't recognize the opportunity to actually use some of the tools that we're given.
Thanks, Shimona. Yeah, I really appreciate that. And I think that aspect of how our trauma shows up, right? We as whole humans in our role as nurses. And again, like that's why all the hero rhetoric really bothers me, because we are full humans who show up in this role, and we bring our own experiences, our own trauma, our own healing and growth or pain into this role. And one of the other things we talk about, and I will share this link for folks, is about an embodied trauma-informed care framework as this way of realizing that when we talk through these steps, we really want to look at it as like healing in tandem with our patients. If we are showing up unregulated and haven't had a chance to address our own trauma, absolutely that rolls into our interactions with our patients. It can make it so that we are not able to see or appreciate their unique situation because we're projecting, right, our past experiences on it. And it can make it so that we also kind of put our head down and just accept things that, yeah, I guess this is just how it is, right? Rather than taking the time to dig in. And as you mentioned, the post-traumatic growth that can come from these experiences and the way that we can then, adapt, change our practices to reflect and live that is really powerful. So I appreciate that reminder.
I also love what you said and about the research and just leadership's role that they play in that ownership. I tell people often that like you can make a really pretty rose, but if you stick it in the desert, it's going to die. And we can teach individual nurses what this looks like, what that feels. But if the leaders, aren't committed to creating those cultures where I can speak up safely, I can, I do have a right to veer from the norm to meet a patient's needs. If they don't create that environment, then it doesn't matter how much each individual nurse wants to do, it just can't happen. And then that's where people lose faith in the system. And they definitely start to, I guess, even feel not empowered themselves. And if you don't feel empowered to make a change or do something, then it's really hard to empower somebody else. So it has a trickle effect.
Those are both great points. Several times, Shawana, you mentioned respectful maternity care. So I kind of want to delve into that. Can you explain what the key elements of respectful maternity care are?
Yeah. So as we developed our framework, we did lots of research and looked through lots of evidence to kind of see what were key elements that needed to show up every time between not only me as a patient showing up with all my needs, my cultural norms, my past experiences, and the healthcare provider that's also showing up with their lived experiences, policies, structural, implications that are involved in, delivering care. And how do we figure out in the middle, how do we get both of those parties together for the best outcome for the patient, not the best outcome for my personal statistics or, not even just the best outcome for a fun experience, but overarching what's the best overall outcome. And in that, we started with that awareness piece. And making sure that when you're aware of the opportunities for yourself as well as the patient and having those conversations of awareness, educating yourself so that you are aware on trauma-informed care and why somebody may be showing up the way they are so that I can, approach them in a better way. We also look at the shared decision-making and informed consent. We look at mutual respect, dignity, accountability, and jump in for me, Sarah. I think I got them all right.
Autonomy.
Yep, that's the other one. And those key elements and making sure not only for our patient, they understand these, but also for healthcare providers to understand both aspects. And so I always say there should be this shared accountability in this model that not only our healthcare providers are holding themselves accountable for showing up and delivering this type of care, but our patients also know and understand what does that mean when we say autonomy? Like that I have authority and I have the ability to make decisions of my care. And so they're expecting that delivery of care. It's not just me knowing, but also on the other end, there's that shared accountability happening and mutual respect. And then looking at even, I tell people about dignity, and dignity is not just protecting my personal information and turning over your chart so they don't see. Dignity is not just, covering me up so somebody doesn't see my bottom because there's 5 residents in there. Dignity is when you see I'm being vulnerable or I may be in an unsafe place, protecting that. Protecting others, making me feel like I'm less than or I'm being dismissed or disrespected, like protecting me from that. That's a part of the dignity. Because if you think about the more people experience these things, the more they feel less than, the more they don't feel safe. So dignity isn't always physical. It's sometimes that emotional space that you think about labor, you're most vulnerable in. Hormones going everywhere, you're in vulnerable positions and, so you're needing more than just cover me up. After you came in, it is speak to me, acknowledge me, reinforce, advocate for me. Some of those help with that dignity piece that I think I really appreciate. Respectful maternity care really digs in a little bit deeper.
I like that definition of dignity as an action word instead of just like some obtuse principle that, binds us in the back of our mind.
I think AWHONN in their definition defines it almost like it says it's an inherent right? So it's not something I get to give you. It's something that you show up with and I should respect that. I always give the analogy of when you show up for Chick-fil-A, even if you had a bad day and cuss them out, they're going to hand you your bag and say, it's my pleasure to serve you. And I think when we think about healthcare, we have to take in consideration that my bad day has nothing to do with the service sometimes. And that, it still should be, it's our obligation as healthcare professionals to do what's right and cause no harm. And so we have to show up in that way. And you don't have to earn that. It's something that's your inherent right for us to do.
That's also pretty profound, saying that our patients don't have to earn it, because I think we've all, like, as bedside nurses, been in that position where we've had someone read us our rights and you don't really feel that great about, like, having to take care of them. But I mean, I feel like a lot of times you talk to people and you hear what they've been through, and it's kind of like, if I was in that same position, I probably react the same way. Sometimes just the choices they have, not the choices they made. So that's really convicting, I think. So talking about the RMC implementation toolkit, it follows a structured 10-step pathway. Why is having this clear stepwise approach important when organizations are trying to move from intention to action?
So to rewind,
Well, I was going to say, I'll challenge you to say, is it clear? Because the path to get there isn't always clear. And I like to reference that paths aren't always straight and narrow and go in the same direction. They're all strategically curved to get each individual to the destination, navigating the territory that they may be placed in. And so I'm not sure it's always clear, but it is definitely outlined, because we do know that when you sometimes life happens and you might have to reset and, readjust your awareness, reassess your readiness, because we thought we were all in. But when you say we got to do what? We might have to go back to the drawing board, because we might not have structures or system supports in place to allow us to do that. We might have to reach out to Maggie to say, hey, I thought we were good, but we need some trauma-informed education here or support for our leaders, because it's just not getting there. So I think it's clear in outline steps, but we do know that it is something you might have to do a little dance back and forth until you find your rhythm to truly execute all of the steps on the care path.
Yeah, it's kind of like when you're following your map on your phone. If you make a wrong turn or kind of veer off the wrong way, like, it's going to get you there. It just might go through a few detours on the way there. But yeah, to rewind, the 10-step care path that we've developed for respectful maternity care stands for confirming commitment, assembling a multidisciplinary team, readiness, educating all, followed by proposing policy, adapting the culture, assuming accountability, and then tailoring your data management, testing your measurements, and then having a celebration to really sustain that equitable, respectful care. And as Shawana mentioned, it definitely can not necessarily go in that order. You might need to go back and reframe how you did some of the other things and just continuously cycle around to continue to really change that culture. So we know that good intentions don't change systems, really the structure does. So we're trying to help really build that structure from the ground up with this 10-step care path to help with from leadership to healthcare team member commitment to aligning the policies to measuring the impact. So we want for respectful maternity care to be that standard practice that everybody is providing, not just something that depends on those ideal conditions or the individual itself.
So both RMC and it sounds like Maggie with the trauma-informed care lens talk about policies and updating and revamping policies. And I've written tons of policies. So how would you advise somebody that's in the leadership position? How do you do that with the trauma-informed care lens? Instead of just saying it, how is that done so that we reduce re-traumatization for both staff and patients?
I heard, Maggie, you said when we were talking about the leadership structures, like there needs to be clear policies to help support some of those systems. One thing I like to think about is that policies don't truly change practice. People do. And if we don't set up the right structures, then I don't care what policies we put in place, they are not going to change the thought process of people. And that's what we truly have to change. I do think you need to have clear policies on how to maintain sound structure. So if I report something, there is no fear of retaliation or anything like that. And so I think policies need to be more around that structure than having a said policy for respectful maternity care. What does that mean? Because in my eyes, that means having flexibility and being able to adapt care. Sometimes we hold ourselves into very strict standards because this is how we want people to be compliant. But some of those strict standards are the ones that are not allowing us to shift and meet the needs of different patients and different populations. So you have to be really careful, I think, when you're making policies to take in consideration what flexibility or what leverage you may have to flex away from those. And you don't want to pigeonhole yourself into saying, I do this every single time. And that everything may not be appropriate for every single patient. I remember giving a presentation, and I think it was the Iowa's chapter conference and for AWHONN, and the lawyer talked about being really careful with policies and how strict we make them, because some of those are what allows us to show up and only care for patients this way, or care for every single patient the exact same way. And that's not what every single patient needs. So I think we definitely need them in place to help support the structures. But I would say be careful about how tight you make those policies, because they can very easily hinder your ability to really individualize care or to flex to meet the needs of our patients when it's appropriate. We know every care practice, I would like to say every delivery went the exact same way, but even in the same room with the same equipment and the same team, every one of them comes out different. And so how do we make sure that we're keeping them tight enough so that we're safe, but we do allow to adjust to do what's best for each of our patients, and because they have autonomy to say this isn't right for me, and we have to be able to trust that. But I think sometimes people don't trust the opinion of the patient, because if I allow them to do that, oh my gosh, I might get in trouble because I was told to do something else. So I think we just have to be careful. I think they're important. I think they need to be there, but I do think each organization needs to be thoughtful in which types of policies they put in place. What do they say? And do they contradict this care model that we're trying to put out there?
Yeah, thanks, Shawna. I appreciate that point. And I don't think it's so much that someone needs to have a respectful maternity care policy or a trauma-informed care policy, although in some environments that might be what's most helpful.
Oh, girl, in the first round, we thought that's what should happen. And we probably said that and gave you one because we thought that. But over time, we've grown and learned and heard that, oh, that might not have been the right thing to do. So don't worry. We thought that at first, too.
Yeah, exactly. So if you are listening and you have one like that, you're not doing anything wrong per se. And
no.
I think, the point that we want to make is really looking at your policies to see if they are limiting you from applying trauma-informed care, from providing respectful maternity care. And I can think of a couple examples that may be helpful for folks. So for instance, if you have a policy that requires for everyone to receive a cervical check upon their admission to labor and delivery, and you have a patient who comes in and does not want to have a cervical check at that time, and the nurse sitting there feels like that rock and a hard place. I'm wanting to respect my patient. I understand they're maybe coming in with trauma. They don't want a cervical check right now. I'm also looking at my policy that tells me I have to put this number in before I'm allowed to move on with their admission. That is one of those policies that we can get rid of, right? We can change to, talk about shared decision making, and in consultation with a patient, deciding when it is appropriate, or if and when it's appropriate, to perform a cervical exam, stuff like that. When we're looking at visitor policies, do you have one that says only 3 people are allowed in, delivery room, and you have someone who maybe it's for any number of reasons, maybe they're a younger, patient, maybe they've got some other particular trauma histories going on. Maybe they just really need to have their partner and their mom and their sister and their doula in the room. And that is what's going to make them comfortable and improve their experience tenfold. And the nurse is sitting there saying, I only get to give out 3 bands. I have 3 bands here, and there's 4 of you, and I literally can't make this happen. Then that's another structure that we could look through, right? And that could, again, be in consultation and could be in relation to the rest of the dynamic of the unit, or, in discussion and reminders about, et cetera, et cetera. So I think it's looking at those kind of places, looking at, all of the different things that we talk about, evidence-based care. Are there options where our policy is making it so that our patients have to do one thing, right? Or would put the nurse in a position where they say, I'm not allowed to XYZ. Anytime that we have a policy that is making it so that the nurse feels like they have to control the patient's choice for their care, that's the kind of policy that we want to see changed, so that instead it is centered around patient autonomy, their consent, that they have respect, that your care is being delivered equitably, and that it has looked at all of those factors. And again, a lot of that comes into, shared decision making, and language and policies can really reflect that. And coming back to consent, autonomy, respect, equity, the care framework that I talk about, because if we are doing those in each of those interactions and our policies are built to make sure that that happens, then we're not going to run into these instances where patients feel like they're not being heard, where nurses feel like they're caught in the middle and fighting against the system to provide the best care for their patient.
Yeah. Thank you. I love the explanation. I love the examples. It makes it real so that you can actually see and start looking at your policies and see what's vibing and what's not, and which policies are going to allow your culture to change. So what does adapting culture look like in terms of maternity units that are trying to center dignity, equity, and psychological safety? Since you've done all the research, Shawana and Maggie, what does that look like?
Yeah, I think adopting a culture, I think it first addresses awareness of your culture. What are your demographics? Because my demographics may look different than yours. So I can't go and cherry pick a product that was great for, decreasing care in African-American women if that's not even my population. So really evaluating what makes your population different, what causes care deviations or different approaches that need to, be integrated into your care delivery. You really have to dig into your demographics. What's the population that I serve? What are their needs? So being aware of that, and then what resources do I have? Who do I have caring for these patients? And, what are their beliefs? And that's one thing in the work with Respectful Maternity Care. They do an assessment of ideas and beliefs of nurses, because I think that's important. Because it's important to make sure that you have a shared vision for outcomes of care. Otherwise, you're going to always have a clash. And, from being a leader and doing lots of leader rounds on patients, following up on patient complaints, the one thing that I think was probably my special sauce or superpower in that was truly listening for the underlying problem, because a lot of times what they were saying wasn't necessarily the issue. And so I had to understand where they were coming from. I had to understand just because a patient complained about a nurse didn't mean it was the nurse's fault. It could just not have been, they may not have been on the same page with things. So really just getting to know your culture, knowing your team, knowing your structures, your, things that you already have in place that may be hindering you from being able to create that environment. I like to always share my concept. I call it the cookie theory, the cookies and cream theory. You can't say Oreos because it's trademarked. But when you say that word, people know exactly what you mean. They know you mean 2 cookies, cream in the middle, right? That's their standard. And over time, they realize that other people like different flavors, different types. And so they adjusted their brand. Still 2 cookies and cream in the middle, but you may get one in a lemon flavor. I really like the Coca-Cola flavor. Don't judge me. It has Pop Rocks in the middle. But there's a different flavor for everyone. There's minis, there's double stuff. They even have these cakesters now that my son likes that are a total different texture, but they're still that same standard, 2 cookies and cream in the middle. I think when you look at your culture and what standards you're putting to adapt, you need to make sure that you're leaving room for flavor. So what are our standards? What are our 2 cookies and cream in the middle that's happening for every one of our patients every time? But how much variation are we allowing to adjust to that individual patient's need? Kind of to Maggie's point, like if they require more than 3 bands, because there is adoption situation, have we left room for that? Or have we made our structure so tight that we're not allowed to do that? So I do think that is important in looking at all of those elements. I don't think it's an isolated thing. I think it's something that you have to do throughout the whole process. So from assembling your team, like who all is on the team depends on who all is impacting care. Doing a readiness assessment, looking at it through a lens of maybe something non-traditional. Because I've had people to say, oh, we don't really have a lot of diversity in our facility. Oh, you do. because they may show up with different birthing preferences. Your mom that wants a natural birth versus an epidural birth, their preferences are way different. And they may be the same color, same culture, and, same marital status, but they have different beliefs and wants. I think it's also really challenging yourself to think outside of the box of the things you can control. A lot of times when we're trying to adapt the culture or get people to take on things, it's telling them what to do or the policy says, but really bringing them into the decision to really think through the things they can control and own. This is my professional governance helmet I'm putting on. It's super important because when they have buy-in and ownership on some of those decisions that need to happen in the cultural change, they own and they take responsibility for what needs to happen. But if we dictate and tell them this is what needs to happen and they don't quite understand, that's the same reason they don't understand the needs of the patients. Because it's just not really, that dialogue hasn't been there. So we have to make sure we include them in the change, that we truly understand all the changes that are happening. And we have to also understand the shifts that are going to occur when we start asking people to change. I can remember going to a meeting where they said, if you witness a behavior that you don't feel is just, speak up. I remember the first time I spoke up and the providers looked at me like I was crazy. And I was like, that's what y'all just told me to do. This was your meeting that y'all talked about this, but it feels different when it's happening to you. And so it was just a learning curve that we had to work through and reiterate, we still have a solid relationship. I still respect you. But if we're saying we're going to speak up, that could feel uncomfortable. And so, now we might want to prepare providers for what it feels like if someone challenges your thought in the moment. How do we handle that respectfully in front of our patients? So adapting to culture is a massive ongoing approach that we have to take. And we have to look at all the different elements. We have to look at the ripple effect of things that we shift and change and how do we control for them. That's why I like the term path, because it's not, like I said, it's not clear. It's not straight. Sometimes we have to adjust when it rains. Sometimes you can't go this, you got to make a different route because now there's a puddle. So we have to look at adopting a culture as an ongoing thing. It doesn't stop because you hire a new nurse, my culture changes. You get a new population. Look at generations. As generations are changing, their communication, their interaction is different. So it's not a one-stop goal when you're adopting change. It's definitely something that has to be an ongoing everyday shit. Well, not every day, but regularly assessed for opportunities process as we're looking at that. I think I answered what you said. I don't know.
I think also Shawana, I think you touched on it a little bit, but I think it also really goes to adapt the culture really starts also with that self-awareness and self-reflection on how you're showing up, as you mentioned, and just how you're caring for the patients, how you've practiced prior to really knowing the elements of respectful maternity care or knowing about trauma-informed care. It made me think of when I had an aha moment when a loved one was in the hospital and I was feeling really helpless. And I thought, this is how families feel when their loved one is getting ready to give birth. It is such a helpless feeling knowing you're not in control. And so as I was sitting in the room, I looked up and on the whiteboard, there was a sign talking about narrating care and care narration and making sure that you're doing this. And as I was reflecting on that and working on the Respectful Maternity Care program, I thought, talking through what you're doing isn't really respectful maternity care or trauma-informed care. I mean, you can talk through what you're doing. And as I reflected on my past, how I cared for patients, like I'm going to press on your belly now, I'm going to check you really quick, I'm going to check your blood pressure now, I'm going to take your baby to the nursery to have a hearing screen, I'm going to do whatever. We're not asking for we're telling them what we're doing. We're not asking for permission. And so really that care narration needs to be shifted to be a care permission. So do we have your permission to do this? And really, when you're asking for permission to do these different things, you're giving them the power of making a decision and really that control of they have the control on even if it's just, is it okay if I take your blood pressure right now? And, that's giving them a little bit of control at a time that they do not have any. So I think that culture shift even needs to go all the way down to just that reflection on how we've been caring for patients, how we've been, trying to talk through what we do really, but really what it needs to shift to is just asking for permission if we can do these different things to give them that sense of control. And as I reflected on my prior practice, I also always land on the Dr. Maya Angelou quote, you do the best until you know better. And then when you know better, do better, and think, okay, I know this better now, so I can do better. And then I can help inform others to help. Hopefully other people will make that change as well.
Yeah. As I listen to you, Sarah, I'm thinking like, I wonder if there are people listening that'll be like, yeah, right. Like, I don't really have time to ask or, slow down to do some of those things. But I think that's why it's important to start it in the beginning. So you have a clear relationship with your patient so that when something does turn emergent, they already trust you. So you're not building that trust in the emergency. You're building it over time so that you're not having to do something extra. I think I heard this earlier, like it's just kind of what we do. And I think sometimes as healthcare providers, you shut down because as soon as you say, well, let's ask for this, let's ask for that, your mind goes to that. Speaking of trauma, goes back to that bad experience I had and I didn't have time to ask her, or I didn't have time to do such and such. Instead of, if I would have started earlier, when I assertively said, hey, we have to move this way, you would have trusted me to know that we're doing the right thing, for your outcomes. But if you don't establish that along the way, and then you wait until the trauma or the emergency to trying to do that, that does feel like extra work and extra things that we have to do different. We used to serve I worked at a facility where we served Mennonite patients. And when they would come, they didn't want any, they refused all treatment. And so one thing I found that it was always helpful if I started by building a relationship, and I totally respect all your wants and wishes and, and I'm going to, honor those. But if there's any point in this time where I start to feel uncomfortable with the care of you and your baby, and I look at you and say, hey, I need to start this IV, I would like you to trust me on that. Because it's going to be this, but because I know you don't want it until we get to that point, totally, let's respect that. And then let's have a conversation of what should happen if I get that point. Are we okay with that? And usually because I had that conversation, they trusted me. 9 times out of 10, we didn't even get to that point, but I felt safer knowing that if I needed to, they trust me to do it. They felt safer knowing as long as I don't need it, she's not going to force me to do it. And so it was that mutual respect that was happening that allowed, for a better relationship. And I think sometimes I just wanted to bring that up because as I was hearing what you were saying, I'm like, great stuff, great stuff. And then I was like, I wonder if people are like, well, how am I do that? How am I going to do that? I don't have time. Like, sorry.
Shawana, it's really interesting that you say that because as you and Maggie were bringing up some examples, like the cervical exams as a barrier to entry, I did have in my mind, like, just knowing how busy my facility is, not so much like pressed on time as much, but like pressed on resources with us all being so short staffed and so many maternity centers closing. So the facilities that are still in existence really absorbing that, but not really able to increase their staff or staff safely per like AWHONN or any of the standards that we use. It made me think about just how your points about system-wide engagement in these policies and like system-wide buy-ins really affect how effective and how these programs and toolkits are going to be able to be implemented, because you can have those individual nurses wanting to do like every single thing, but like if there aren't staff in place, if there aren't systems in place, if there aren't rooms there, it really does act as its own barrier to like really being able to provide the care that our patient population and our staff really need to be able to provide both respectful and trauma-informed care to these patients. You can kind of see how like the weight of the system, a system that doesn't work, kind of like rears its ugly head when it comes to like day-to-day implementation of these like really vital means of care for our patients.
Yeah, I think it's really one of the other areas of my research is into secondary traumatic stress and burnout in nurses. And hearing you say that, I know that I have felt that as a nurse when you are doing the most, right? You are trying to do everything that is possible in your power and beyond, right? To provide the best care to your patients. And you feel alone in the system. You don't have the resources. You need to do your job. You're working with challenging colleagues. Like there can be so many challenges. And so a shout out to the nurses who are listening to this and are feeling overwhelmed and are worried because they would love to do all these things and they are not currently working in a system that supports it. I want to call out a couple of things. One is that we do not have to stay in bad environments. We do not have to keep pouring ourselves into it when we are not in a supportive system. And so I want to just say that I embolden you. Sometimes we have to do some really, really hard internal reflection work to realize if this is a moment for us to take charge and be the change we want to see in the world and all of those great cliches, or if it's a time for us to say, I have poured everything I can into this system and I need to leave now for my well-being so that I can create something sustainable. The other piece of it is that when nurses keep pushing past their capacity and they do not have system support, they burn out. They experience secondary traumatic stress, they experience moral injury, and they leave our profession. So for the leaders who are listening to this and are not sure if they can make this happen or if we can prioritize it or they're not sure about the budget, we really have to keep looking at this as like systems layers out to see what the influence and impact of our policies are on not only our patients and their experience of our care, and also our staff and the clinicians who make it possible for us to provide this care. And it is increasingly obvious to me that this is really not negotiable. It's not optional. It is the way we have to move forward if we expect to have a nursing workforce to provide care for our patients, full stop. And I also do not, that's not a dig at any particular leader, because again, it's not one person's job, but this is where all of us have to be looking at where are our opportunities to advocate for safer staffing ratios, to come to AWHONN on the Hill, right? And push for policies on a big scale, right? That creates safer care environments for us and for our patients, rather than internalizing this. So often I felt like I was personally failing because I was not able to create and push for the change that I knew needed to happen. And I don't want other nurses to feel that way. I want us to be realistic about our capacity, about caring for ourselves as humans, and pushing for the change when we have the opportunity to do so.
And it takes all of us. It not only takes all of us in the national level, I'm just going to tag on to what you said, Maggie, but it takes it in the regional level. Like, not only do come to AWHONN on the Hill, we'd love to see you there, but also what are you doing at your regional level? Are you going to your own, like I live in Texas, so we're doing a virtual AWHONN on the Hill version. I'm going to do that because I need to talk to our legislative staff or legislative leaders and ask them for what we need here in Texas. Are you doing that regionally? And then as nurses together, you can change systems, right? But it can't just be one person. It has to be everyone together in that system to change it and to support the leaders to make this change. And so I really thank you, Maggie, for bringing that up, because you're right. If we don't change things now, if we don't adapt the culture that Shawana spoke to, if we don't look at the multi-layers that Sarah spoke to about ourselves, we're not going to have a nursing workforce come. We're already short, very short. And I know we're coming to time in a little bit, and I don't want to miss the opportunity to talk about how the Respectful Maternity Care program has grown. It's going through another iteration, and that iteration is designation. So do you want to tell us a little bit about the designation process and what's coming up?
Absolutely. So we have a brand new Respectful Maternity Care designation program that will be launching this month in January 2026. So with it, you can apply we have 3 different levels of designation: bronze, silver, and gold. Bronze level of RMC designation is you have gone through implementation of the 10-step care path. So you have went through each of the steps, the 10 different ones that we mentioned, as far as going from confirming commitment to having a celebration at the end, but you have implemented all these steps. That would meet the criteria for the bronze level designation. The silver designation is you're making a difference to the patient, so you're having that perception change. So you can see perception change with both patients and then also with the healthcare providers and professionals attitudes and beliefs about birth. So you've really made an impact on the perception of how that respectful maternity care is being understood, or really what it looks like in your organization. And then gold would be you're having an outcome or making a difference in outcomes. So maybe before, when you stratified your data for different areas that you noticed some differences in outcomes for groups that you care for, now those differences have really went away. You have an improved outcomes related to the maternity or respectful maternity care that's being provided. So you can go from implementation to really that outcomes change with the designation.
I just think that the designation is a way of kind of positive reinforcement, also acknowledging sites that actually put this into play. I think it also allows us to have connections with facilities, one, to continue to grow our resources in the RMC toolkit. As I said, it like care evolves. Politics evolve, cultures evolve, policies change. And so just being able to make the right changes, I think it's important to have connections with facilities that are actually exemplifying the practice, like, and making impacts in those areas. Jessica, I think earlier you kind of just talked about that ownership of person and being able to own like what you can change in your facility, speaking up, being a part of your shared decision-making structures at your facility, to actively speak up about, hey, I really want to deliver this care, but we don't have the time and resources. And here's the evidence that says that we need more. And so, being a part of that change, not being scared to speak up. And Maggie, I love your point about nurses being burnt out. Sometimes when you say be the change you want to see, people often misinterpret that as endure what's happening and, push through. I don't mean endure. I mean change. And so in patient rounds, I heard a patient say they weren't heard. And I kept saying, well, what's going to happen when I'm not here? So I got involved with AWHONN and started helping to develop this toolkit and this framework because I didn't want other people to experience this. So being a part of the change I wanted to see means getting involved with your local chapters, being a voice, helping to advocate for those things, suggesting new ways of doing things. And like you said, locking in, but don't do it at your own expense to just keep enduring the same problems. By all means, I've always told people if they don't have a seat for you at that table, they will use your same skill and talent somewhere else and they'll appreciate it. And so don't be afraid to move your seat if you don't feel like you're able to show up your best self, because you're not doing anybody any justice by showing up at a table just because. If you're feeling devalued, you're not going to be able to do exactly what we said by pouring into someone else when your cup is empty or it's not filled with the right stuff. So we got to start with our self-care first. So I love that. But I think a professional obligation as nurses, you don't need a structure to do that. You've owned that when you became a professional nurse. And how do you find ways to do that? And I love that AWHONN creates a space for every maternal neonatal nurse to connect with, have a voice in the policies and the practices that affect our work. So I don't know if they had anything with designation, but I think the designation helps to validate that. And that is evidence-based principles being put in place. And I think that's just respected in general. I think for organizations, it also helps a reputation. And so when I'm branded as such, people know when I show up to that facility, I should automatically expect that. Just like the Chick-fil-A brand, they show up knowing they're going to get that care regardless. And if you're branded with one of those designations, I would hope that that's your culture and is carried out all the way through to your patient outcomes and nurse satisfaction or provider satisfaction at that facility that says you practice in a respectful environment, you respect trauma-informed care, and it's a part of our standard practice.
And that national recognition, we will have a webpage with all of the sites that have achieved the Respectful Maternity Care designation listed on it, with a map that you'd be able to see where everybody is located once that does get started. And then it also puts you in touch with all the different people who have received this. So you can really see, okay, what is working, what isn't, how do we keep this momentum going? And so it gives you that network of people that you will be able to continue to evolve and change with as well.
I was writing as you all were talking, and if I were a nursing student or a professor if I just started on the L&D unit this past summer, or been a postpartum nurse for 25 years, if I lead my clinical unit, serve as the CNO, or am in the last few years before retirement, I'd want someone to be sure this episode about trauma-informed care and respectful maternity care was shared with me, because there is no nurse serving patients that this doesn't apply to. So I want to say thank you, Shawana, Maggie, Kimber, Sarah, and Jessica, for all your life experiences that led us to be together for this opportunity to share knowledge and action steps. What I heard today is that there is no glass ceiling that a team cannot remove in order to implement these evidence-based concepts that result in better care for patients and nurses. For all of our listeners, if you'd like to take advantage of the resources shared during this episode and read our guest bios, visit awhon.org/podcasts. As a reminder, to receive the contact hour for this continuing education activity, participants must listen to the entire podcast episode, complete the evaluation in full, submit all required documentation by the stated deadline. This enduring material will expire January 20th, 2029. Also, be sure to subscribe to AWHONN on multiple streaming platforms so you can catch any episodes that you've missed. You can also follow us on AWHONN's YouTube channel. Please recommend this episode or any of our episodes to a colleague or friend. Feel free to reach out and leave us a comment about your listening experience. Thank you all again. Be well and stay safe.